If you're over 65, is 140 over 90 actually normal for your age? What about 130 over 80? And can your blood pressure actually get too low as you get older? Those are questions I hear a lot. And the honest answer is a little more layered than a single number on a chart. Here's the short version before we get into it. Blood pressure commonly rises as we get older, but common does not mean normal. Those are two different things, and mixing them up is where a lot of confusion starts. In this video, I'm going to walk you through what current guidelines actually say, why blood pressure tends to change with age in the first place, when a lower number becomes something worth paying attention to, and what questions to bring to your own healthcare provider. So let's start with the basic question. What is considered normal blood pressure after 65? The normal blood pressure category is still a top number below 120 and a bottom number below 80. That doesn't shift just because you turn 65 or 75 or 80. What does change is how common it is to see readings above that as people get older. So here's the distinction I want you to remember, because it's really the whole point of this video. Average blood pressure at an older age and normal blood pressure at an older age are not automatically the same thing. A reading can be common in a certain age group and still not be considered normal. If this is helpful, give me a quick like so I know to keep making videos like this. Now, if below 120 over 80 is still the normal category, why do so many people end up with higher readings as they age? That comes down to what's happening physically inside the arteries. When you're younger, your arteries tend to be more elastic. Each time your heart beats, the artery walls stretch a bit and then recoil, which helps absorb some of that pressure wave. As people get older, arteries commonly become stiffer and they don't expand and recoil the same way. So that same pressure from each heartbeat has less give to work with. And the top number, the systolic number, is often what climbs as a result. This is also where a specific pattern shows up in a lot of older adults called isolated systolic hypertension. That's when the top number is elevated while the bottom number stays considerably lower, sometimes even in a normal range. It's a pattern related in part to how the arteries change and stiffen over time. But it's not something to brush off as just normal aging. It's still high blood pressure, and it's something your healthcare provider will want to evaluate and manage. So with all that in mind, what number are doctors actually aiming for when they treat blood pressure in someone over 65? According to the 2025 American Heart Association and American College of Cardiology blood pressure guideline, the overall treatment goal is below 130 over 80 for adults with high blood pressure, and that includes older adults. But I want to slow down one part of that sentence because it matters. There's a difference between the definition of normal blood pressure and a treatment target for someone who already has hypertension. They're related, but they're not identical. Normal blood pressure describes a category. A treatment target is the goal a healthcare provider is working toward when managing someone's high blood pressure. And age by itself doesn't automatically bump that target up to 140 or 150, even though those are numbers a lot of people remember hearing years ago. If you've got a parent, a spouse, or maybe you're managing blood pressure yourself, and the number don't seem to line up with what you were told years ago, let me know in the comments what questions you're running into. I read through these and it helps me figure out what to cover in future videos. Now let's flip this around because this is where the conversation gets even more interesting. Can blood pressure actually get too low? Yes, it can. But I want to be careful here because there isn't one universal danger number that applies the same to everyone. What matters is the number along with the person's symptoms and overall health. Things like dizziness, lightheadedness, weakness, fainting, or unusual fatigue can be signs that deserve attention. This is also a good moment to talk about the bottom number, the diastolic pressure, because a lot of people focus almost entirely on the top number and forget that the bottom number tells its own story. A diastolic reading below around 60 can be something a provider wants to look at more closely, particularly in an older adult or someone with coronary artery disease. But that doesn't mean every single reading below 60 is automatically dangerous or that it's causing a problem with blood flow to the heart or other organs. Context matters. Your healthcare provider is going to look at the whole picture, including your symptoms, medication, other medical conditions, and what your blood pressure has been doing over time. And if you've got symptoms or health numbers you've been meaning to bring up at your next appointment, I put together a free doctor visit health checklist for you. There's a place to write down your symptoms, current medications, recent health numbers, and the questions you want to ask so you don't forget them once you're sitting in that exam room. You can download it free using the link in the description below. Now, there's one specific blood pressure problem I really want people over 65 to know about, and that's what happens when your blood pressure drops after you stand up. It's called orthostatic hypotension. Clinically, it's defined as a drop in systolic pressure of at least 20 points or a drop in diastolic pressure, the bottom one, at least 10 points within 3 minutes of standing. If you've ever stood up and felt the wave of dizziness or unsteadiness, you know the kind of symptom we're talking about. But feeling briefly lightheaded doesn't automatically mean you have orthostatic hypotension. The diagnosis is based on actually measuring that drop in blood pressure. In older adults, orthostatic hypotension can be related to certain medications, dehydration, or changes in the way the body regulates blood pressure. And that's one more reason symptoms matter, not just the number you see while you're sitting in a chair with a cuff on your arm. Now, I want to bring in one important study because it helps shape a lot of the thinking behind tighter blood pressure control. It's called the SPRINT trial. The SPRINT trial compared two different systolic blood pressure targets in adults at increased cardiovascular risk. One group was treated toward a more intensive target of less than 120. The other group was treated toward a standard target of less than 140. The group treated toward the lower target had fewer major cardiovascular events and lower mortality during the study. And this wasn't just studied in younger adults. SPRINT included a large group of adults 75 and older. And that older group also showed cardiovascular and survival benefits from the more intensive treatment. There were trade-offs. Intensive treatment was associated with more treatment-related problems such as episodes of low blood pressure and acute kidney injury. But importantly, the study did not find an increase in injurious falls in the adults 75 and older who received intensive treatment. I'm not going to turn this into a full clinical trial breakdown because that's not really the point. The reason sprint matters here is that studies like this help move blood pressure guidelines towards tighter control while still recognizing that the healthcare provider has to consider the individual person sitting in front of them. And that brings us to what might be the most important part of this whole conversation. When does the target need to be individualized? There are situations where a healthcare provider may adjust the approach for a specific person rather than chasing the same number at all costs. That can include things like significant frailty, limited life expectancy, symptomatic low blood pressure, recurring dizziness or fainting, fall risk, difficulty tolerating medications, or several medications that have to be managed together. I'm not going to hand you a replacement number to adopt on your own because that's generally not something a video can responsibly do. The answer isn't that everyone over 65 should simply have a higher blood pressure. The answer is that treatment has to fit the person, not just the number on the chart. So with all that covered, what should you actually do with your own numbers? First, know both numbers, your systolic, which is the top one, and your diastolic, which is the bottom one, not just the top one. If you're measuring your blood pressure at home, use the validated automatic upper arm cuff. Wrist and finger monitors tend to be less reliable. Before you measure, sit quietly for at least 5 minutes. Keep your back supported, your feet flat on the floor, and your arms supported at heart level. And each time you check your blood pressure, take 2 readings about 1 minute apart and record them. That's important because one blood pressure reading is really just a snapshot. A record of your readings over time gives you and your healthcare provider a much better picture of what's actually happening. If you're experiencing dizziness, lightheadedness, fainting, or other symptoms, tell your healthcare provider about them. And here's a question worth asking at your next appointment. What blood pressure target are we aiming for in my case, and why? That question can open up a much more useful conversation than simply asking whether one particular reading is good or bad. One thing I do want to be clear about: nothing in this video is meant to tell you to start, stop, reduce, or increase any blood pressure medication on your own. Those decisions need to be made with your healthcare provider based on your individual health picture. Over the years as a nurse, one of the most common mix-ups I've come across is exactly the one we started with: treating common for your age and normal for your age as if they're the same thing. They're not. And understanding the difference can make the conversation about your own blood pressure a whole lot clearer. But knowing your target is really only half of the picture. If you're taking amlodipine, losartan, or lisinopril, the next question is, what is that medication actually doing in your body? What should you be watching for while you're taking it? And what should you know about it? That's exactly what we're covering next. I'll see you there.